The cardiovascular system changes significantly after birth. In this lesson, we are going to continue with the assessment and care of the newborn. This is part 2. So when you look at the newborn cardiac function, we're going to talk about average resting heart rate should be between 120 to 160 beats per minute. It could drop to 80 to 100 when they are sleeping. You want to auscultate the apical pulse for a full minute. Uh, Blood pressure is highest at birth and it's lowest about 3 hours of age. The capillary refill should be less than 2 to 3 seconds. Blood pressure is dependent on birth weight and gestational age, and the mean should equal the gestational age. And then you want to check for extremities, all four extremities for the blood pressure at 24 hours. So basically, there's an increase in aortic pressure, a decrease in venous pressure, there's an increase in systemic pressure, and a decrease in pulmonary artery pressure, which leads to the closure of the PFO, the closure of the PDA, and the closure of the ductus venosus. Increased aortic pressure and decreased venous pressure occurs when the clamping of the cord occurs, and then we have the systemic blood pressure rises, blood return from the inferior vena cava decreases, causing the decrease in the right atrial pressure and small decrease in the pressure in the venous circulation. Then we have the increased systemic pressure and decreased pulmonary pressure, as we discussed before, and this it occurs when there's a rise in systemic blood pressure because the flow to the placenta is actually cut off during the cutting of the cord. And then there is lung expansion, which increases the pulmonary blood flow. Sudden increase in the PO2 from that first initiation of breathing causes the vasodilation of the pulmonary vessels. The pulmonary vascular resistance drops, and then blood rushes into the pulmonary beds. Closing the PFO when the baby breathes for the very first time, the pulmonary vascular resistance decreases and there's an increased pulmonary blood flow. This causes the pressure in the left atrium to rise because of blood return from the pulmonary veins. Pressure is in the right atrium drops, and the overall systemic vascular resistance, also known as your blood pressure, will increase as the umbilical flow is stopped upon the clamping of the cord. The change in atrial pressure will actually close the foramen oval. Closing the PDA, the increase in the pulmonary blood flow, which causes the increase in oxygen concentration, as well happens as well as during the clamping of the cord. It causes a drop in the prostaglandin levels. Oxygen causes the pulmonary vessels to dilate, but the ductus arteriosus constricts. This causes the ductus arteriosus to close. This is the official conversion to regular circulation. Functional closure starts 10 to 15 hours post-birth, with complete closure by 4 weeks after birth. Closing of the ductus venosus is thought to be the result of the mechanical pressure changes after cutting of the cord. Redistribution of the blood and cardiac output changes. Closure occurs within about 2 months. This is an image of the, different blood flow through the heart and the pulmonary veins and the lungs. That was just a brief overview of what we discussed previously in part 1 of assessment and care of the newborn. Okay, so let's discuss a little bit about the blood effects. Blood volume of term infant is estimated to be about 85 mLs per kilogram of body weight. It varies depending on the placental transfusion, delayed cord clamping, gestational age, prenatal or perinatal hemorrhage, or site of the blood sample. Hemoglobin and hematocrit levels are higher in the capillary blood than in the venous blood, and venous blood samples are more accurate than the capillary samples. The level of hemoglobin varies with the amount of placental transfusion, low oral intake, and the decreased extracellular volume. There are physiologic anemia of the infancy that we got to take into consideration. It could be affected by nutritional status. Basically, neonatal red blood cells live about 60 to 80 days. Birth stress can stimulate the production of neutrophils, and then lymphocytes are important for AB production. Besides establishing respirations and adequate circulation, heat regulation is most critical to the newborn's survival. During the first 12 hours, the newborn attempts to achieve thermal balance. This is known as thermal regulation, which is a balance between heat loss and heat production. Babies are homeothermic. They try to stabilize their core temp within a narrow range despite temperature variations in their environment. Thermal regulation is tied to metabolic rate and oxygen consumption. We will talk about the key goal to maintaining a neutral thermal environment. Okay, so babies like it warm. Why? Well, they have less subcutaneous fat. Their epidermis is very thin. Their blood vessels are closer to the skin surface. Therefore, the environmental temperature has a great effect on them. Term kids will, put themselves in a flex position. They try to decrease the exposed body surface area, and this will conserve heat. So newborn infants' body temperature depends on the heat transfer between the infant and the external environment. Factors that influence heat loss to the environment include the temperature and humidity of the air, the flow and velocity of the air, and the temperature of surfaces that are in contact with and around the infant. Hypothermia and cold stress are a major threat to newborns. You can lose heat by two mechanisms. You have the shift of heat from internal core to body surface and loss of heat from body surface to external environment. There are 4 ways to lose heat from the surface to the environment. There is convection, radiation, evaporation, and conduction. So let's think about this. How can babies make their own heat? We have increase in metabolism, an increase in muscle activity, and chemical thermogenesis. So non-shivering thermogenesis is unique to newborns. It results in the breakdown of brown adipose fat to fuel metabolism. Brown adipose tissue is the primary source of heat in hypothermic newborns. It will appear in fetuses at 26 to 28 weeks and increases until 2 to 5 weeks after birth. Thermogenesis. A newborn attempts to generate heat with cold stress that imposes metabolic and physiologic demands on all infants, regardless of gestational age and or their condition. Cold babies can develop hypoglycemia and respiratory distress. Term kids can usually deal with this increase in oxygen needs when they are exposed to the cold. Preterm kids cannot. Oxidation of fatty acids will depend on the availability of oxygen, glucose, and ATP. Okay, so let's talk about what does the liver do? Well, it is an iron storage facility. If mom wasn't anemic, then the babies are born with iron stores for about 5 months. Then by 6 months, they need an iron supplement. It houses the glycogen storage and it has a role in bilirubin conjugation, and it affects coagulation. What is unconjugated bili? We're going to discuss unconjugated bili versus conjugated bili. Conjugation. This is the conversion of yellow fat soluble pigment into water soluble pigment that can be excreted. Conjugated, also known as direct bili, results when the liver enzymes attach the unconjugated bili to the glucuronic acid. Then it becomes conjugated. Direct bili is dumped into the common bile duct and then the duodenum. It moves through the intestine where bacteria convert it to urobilinogen and stercobilinogen, and that's excreted through poop. Now, did you know that bilirubin can be changed back to unconjugated bilirubin? This is actually called recycling. It occurs in babies with very high beta-glucuronidase activity, those that breastfeed, and those with the delayed bacterial colonization of the intestinal tract. This causes an increased risk of jaundice. Normal newborn livers have decreased hepatic activity and increased bilirubin loads, which equals a decreased ability to conjugate bili and leads to jaundice. Okay, so what's jaundice? Well, jaundice is the visible yellowish color of the skin in the sclera and is caused by the elevated serum levels of unconjugated bilirubin, also known as indirect bilirubin. It occurs in about 60% of terms and 80% of preterm newborns, sometimes known as breastfeeding jaundice. Can also be caused from the bili not getting out. It usually will develop after the first 24 hours of life. Serum bili levels will peak 3 to 5 days in full-term kids and 5 to 7 days in preterm kids. Treatment is feed, phototherapy, supplementation, and monitor serum bili levels. Rarely will they do a blood exchange transfusion, but sometimes it is required. Okay, so we brought up breast milk jaundice earlier. That is when the bili levels rise again after the first week of birth. Bili levels will peak at 2 to 3 weeks of age. Cause is usually due to too much free fatty acids in the mom's breast milk. If the bili levels reach greater than 20, they will have a temporary cessation of breast milk. This is advised until the actual bili levels do fall back down, and then breastfeeding can be resumed. Here to talk a little bit about coagulation. The liver also plays an important role in blood coagulation. Coagulation factors such as 2, 7, 9, and 10 are synthesized in the liver and activated by the vitamin K. Vitamin K is normally made by normal flora gut bacteria by the age of 9 months. Newborn guts are sterile and have no bacteria. Newborns get a vitamin K shot after birth to prevent clotting problems. You want to monitor for transient thrombocytopenia. Okay, so transient thrombocytopenia is accentuated by phototherapy. It is affected by some of mother's medications such as Dilantin, phenobarbital, and Coumadin. And then some maternal conditions can contribute, such as severe hypertension, HELLP, idiopathic isoimmune thrombocytopenic purpura. Okay, I'm going to talk a little bit about digestion and absorption and elimination. So newborn has enough intestinal and pancreatic enzymes to digest simple carbohydrates, proteins, and fats. At birth, newborns have experienced swallowing, gastric emptying, and intestinal propulsion. Fetal peristalsis is stimulated by anoxia, causing the meconium in the amniotic fluid. Normal for babies to lose up to 10% of their birth weight in the beginning. They'll have a shift of intracellular water to extracellular space and insensible water loss. And then caloric intake is usually less than optimal until 5 to 10 days. When discussing elimination, meconium is the thick black tarry and then later dark green. It's formed in utero from the amniotic fluid, intestinal secretions, and the shedding of the mucosal cells. Newborns pass meconium within 48 hours. And then they have a frequency of bowel movements that do vary. Breastfed babies' stool is frequently early in the beginning, and then stools are loose, seedy, bright yellow, and then formula-fed babies' stool is less, and the stools are green or brown. Okay, I want to talk a little bit about kidneys in the newborn. Newborn kidneys will have full functioning nephrons by 34 to 36 weeks. They have a low glomerular filtration rate. They will have limited tubular reabsorption ability. Therefore, full-term kids are less able to concentrate urine. Most babies will void immediately after birth. So in the beginning, initially they will have scant voiding due to the poor intake. And the goal is to have 6 to 8 wet diapers a day. This concludes part 2 of assessment and care of the newborn.